Good afternoon, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce today's speaker, I have some housekeeping items to review. This CME activity is jointly provided by the Queen's Medical Center and the University of Hawaii Jabsum Department of Geriatric Medicine. As a reminder, evaluations are required for CME credits. You can find the evaluations by following the link in the chat at the end of this talk, or in our email advertisement, or on our website. Your comments are very important to the planning committee and will be used to plan future programs. All speakers are asked about potential conflicts of interest, and these are disclosed on the title slide. Today's speaker has no conflicts of interest with commercial enterprises. It is my great pleasure to introduce today's speaker. Ms. Brittany Evans is an instructor at the University of Hawaii at Manoa Communication Sciences and Disorders Department. She specializes in adult neurogenic speech, language, voice, cognitive communication, and swallowing disorders. Her clinical experience includes serving patients in acute, long-term care, and skilled nursing facilities, as well as outpatient settings. Brittany earned her bachelor's degree in speech and language pathology with a concentration in gerontology from East Stroudsburg University of Pennsylvania, and her Master of Science degree in communication sciences and disorders with an emphasis in speech-language pathology from the University of Hawaii John A. Burns School of Medicine. Please join me in welcoming Brittany Evans.
Hi, everybody. Thank you so much for being here today. I'm going to share my screen now with my presentation. Sorry, hold on one second. Can you guys see it okay?
It's perfect. Thank you.
Okay. So my presentation is on optimizing function and quality of life, the role of the speech-language pathologist in collaborative care of older adults. And the reason I wanted to do this topic, I know many of you are physicians and medical professionals, and you know what a speech-language pathologist is, but in my personal experience, just in the community, when I tell people that I'm a speech language pathologist, their first response is, oh, you work with kids or you help kids who stutter, which we do those types of things. And that is super important. But they're usually shocked when I tell them that I work with adults. So I feel like there is just not a lot of knowledge out there, even just in the community where patients might not even know that our services exist. So I'm hoping to share with you guys what we do, and maybe even some things that I say today will resonate with you for some of the patients that you have, and you can offer these services that could be able to potentially help them. So I'm going to get into a lot of what we do, into the symptoms and what our sessions might look like, just to kind of give you a little bit more insight into our day-to-day. So this is about me. I know I was already introduced, but I did complete my bachelor's. I'm originally from Pennsylvania. I moved to Hawaii 10 years ago. I moved here for my master's program, and I graduated in 2017. Right after I graduated, I went to complete my clinical fellowship at Wahiawa General Hospital, and I worked there up until it closed last year. So once Wahiawa closed, I kind of felt a shift that I still wanted to serve patients, I still wanted to work with adults, but I also wanted to share everything I've learned over the past 7 years with my students and be able to teach them to be a really good speech pathologist and maybe work with adults as well. Something I just want to add is I've always been very interested in working with older adults. I love kids, and I think everything we do for children and their development of speech is so important. But there's something about when an adult has these skills their whole life and then they lose them, and how we can support them in gaining that back and gaining their confidence and just improving their quality of life. That is I'm really passionate about. Another thing is when I actually got inspired to become a speech language pathologist when I was in my first year of college. I went in undeclared, and then my grandfather had a stroke, and I was able to witness a speech language pathologist work with him on his word finding and his swallowing, and it was just really powerful to me. So that is how I ended up here. I just want to introduce you guys a little bit to our clinic. So we actually have a faculty practice in our graduate program. So we operate under University Health Partners of Hawaii, and we provide outpatient speech language pathology services for both children and adults. So I also want to add that our program is the only accredited speech language pathology program in Hawaii. There is a huge shortage of SLPs in Hawaii. I think last I checked, it was at 40% shortage. So that's both in the Department of Education and in the medical facilities on island. So us being able to educate these new SLPs and send them out to serve our community is very helpful with that. The way our clinic operates, we do accept insurance. So me as the instructor, I instruct in clinic and then I also teach some courses. So for clinic, I'm the lead speech pathologist. I evaluate the patient, I come up with the plan and the goals and primarily work with the patient. And then the students are able to come in with me to the sessions so that way they can learn and kind of observe firsthand of how the sessions should look for when they go out into the field. UHP is located on the 6th floor, suite 625 in the Gold Bond building, right across from the Med Campus. So at the end of this session, participants will be able to review the scope of speech language pathology as it pertains to assessment and treatment of communication, cognitive communication, motor speech, and swallowing disorders in older adults, identify key clinical indicators for referring adult patients for speech language pathology services, and then discuss how integration of SLPs into interdisciplinary care teams supports medical management, reduces hospital readmissions, and improves functional outcomes and quality of life. So I'm just going to start with an overview of what we do. So as speech language pathologists, we prevent, assess, diagnose, and treat speech and language communication, cognitive communication, and swallowing disorders in both children and adults. And we're integral members of the health care team specializing in evaluation and treatment of communication disorders, cognitive communication disorders, so like attention, memory, executive functioning, problem solving, swallowing disorders, or dysphagia, and voice disorders. And this is just a general overview. I'm going to kind of dive into each of the different areas so you can kind of better understand the symptoms of the different disorders and how we might support that. So why this topic is so important: early identification of speech and language, cognitive communication, and swallowing concerns, along with interdisciplinary collaboration with an SLP, is essential to ensure comprehensive care planning, improve outcomes, and reduce complications. So if we're delaying referrals or missing referrals, it could result in increased health complications. So maybe aspiration pneumonia, malnutrition, or hospital admissions and readmissions in patients with swallowing impairments. The patient may experience reduced functional independence and therefore a reduced quality of life, and then less than optimal coordination of care among team members. So we want to make sure that we are all communicating together with the patient as a whole so that we're not missing anything. Some common etiologies that we see typically as a speech language pathologist. Now, it's not limited to these, but these are just some common ones that you might be able to think if you have a patient who's experienced any of these, maybe they can benefit from services. So a stroke, traumatic brain injury, concussion, Parkinson's disease, ALS, multiple sclerosis, dementia, head and neck cancer, brain tumors, encephalopathy, and hearing loss. And I just want to add, with concussion, that one is tricky sometimes because usually with concussion, the cognitive effects are sometimes really minor. So the patient might not even know that there's someone that can support that, and they might seem really normal when you're seeing them. And another one, dementia. Although dementia is progressive and we might not be improving their cognitive function, we could support the family members in providing strategies and setting up things for them at home to try to make them as safe as possible and also give them tools to help with their memory. So even though they can't remember, we can kind of train them in using like a calendar or making custom memory books, things like that. So I'm going to go over the role of the SLP in patient-centered care. So we really strive for patient-centered care in our clinic. No two patients that I see are the same, not in evaluation or treatment, because we tailor everything specific to that individual. So patient-centered care, we like to maximize communication, cognitive skills, and safe swallow function. We perform screening and comprehensive evaluations and individualized treatment that aligns with the patient's goals. So what does this look like in our sessions? So the first thing is motivational interviewing during evaluation. So a bulk of my evaluation is just talking to the patient and the family and really trying to dig into what's going on with them and how we can support that. This helps with building rapport. It also helps with, we do open-ended questions. So I'm going to ask them, like, what are some challenges that you had with your speech, and leave it open so they can kind of talk about anything that comes up for them. Activities and materials created to target goals specific to the individual. So I always ask what my patient's interests are. They're way more motivated and engaged to participate in things that they enjoy. So for one example, I have a patient who has aphasia, difficulty with word finding. He loves golf. So I will bring in pictures of different golf scenes, pictures, instead of just using a standard deck of just different animals or something that's not relevant to him. I try to bring in things that they love so then they can talk to me more about that and how it pertains to their life. And then those skills will hopefully carry over into their everyday life. Another thing is we provide a lot of counseling regarding the communication order and challenges. So we've seen a lot of patients who've had these different types of disorders. So it's helpful to be able to counsel the patients through it, kind of remind them of their strengths and the positives that they're going through, and also maybe even expectations. So when I have a patient with a stroke, I don't ever tell them that we're going to work on this and you're going to leave here 100% able to communicate like you were before. Sometimes that doesn't happen. So I usually tell them that this is something that might be a challenge for you during your life, but what you're going to learn here is tools and ways that can support you and ways to work through those moments instead of not really having any control. We also work on collaborative problem solving to empower the patient to progress through challenges. So I usually start my sessions asking the patient what went really well this week, to start with the positives, not just talking about all the things that aren't going so well. And then I ask them, what are some challenges you had? And then I let them share. And then we kind of problem solve together what we could do in each of those challenges to better support them. Another thing is inclusion of the caregiver or family members. So patients know themselves best, but sometimes these patients with communication or cognitive impairments may not be able to fully express everything, and they may also be dependent on their family or caregivers at this time. So they usually have a lot of really good insight for us on what the patient needs help with, and even the caregiver. Sometimes the caregiver has some burnout from having to do things that they never had to for their spouse. So maybe the caregiver wants them to be able to be a little more independent in certain tasks. And it's usually a win-win because then it takes some stress off the caregiver, and it also gives the patient that independence back to where they don't feel really good being dependent on their spouse. So we can kind of work with them together as like a team to kind of discuss what's the best things to work on. Another thing that we do is functional and meaningful outcomes. So one thing is sometimes we give standardized tests, and maybe we find out in a standardized test that the patient's reading is really poor, but that patient doesn't read. They don't care about reading. They don't have to read at home. That's not something that we'd want to target, because although it's an area, a deficit that we can work on, it's not functional to them and it's not meaningful. So there's really no point to work on that. We should work on the things that the patient is struggling with day to day. So this is all what I'm gathering during my assessment and even each week while I'm catching up with the patient, how things are going, and then we adjust as we go. So the thing about person-centered and partner-centered care is it helps build rapport and understanding with the patient. The open-ended questions help them share as much as possible. It helps them to kind of gain trust in you because it shows that you're really listening to they what they want and the areas that they really want the most help in. So some examples of questions that I might ask are like, how do these word finding skills happen when you're out in your daily life? So I might ask them, you mentioned before that you're avoiding group conversations. What's the most difficult part about that? So just having them reflect and share, because it might be something that I didn't even think of. Okay, so now I'm just going to share about our role in speech and language. So the most common thing I think most of you probably know about is aphasia. So this is when a person has trouble understanding, speaking, reading, or writing. And this usually occurs after a stroke, but can also occur after any type of injury to the brain. So it could be TBI, brain tumor, surgery. And aphasia can affect the expressive language skills or the comprehension skills. So expressive language skills, you might see difficulty with word finding, struggling to say a specific word or get a word out, saying the wrong word. So they might say apple instead of banana, switching sounds in a word, or difficulty saying longer sentences. Maybe they're speaking to you in really short phrases because they can't put together the longer sentences. Difficulty in comprehension could look like difficulty recognizing objects, difficulty following directions. So maybe you're doing an exam on a patient and they're having a really hard time following what you're asking them to do. Difficulty understanding in conversation. So they might be nodding along but not really know what you're saying. And understanding meaning behind words. So people with aphasia can also experience difficulty with reading, writing, and numbers. So this could include like reading signs, filling out forms, or reading books, spelling and putting words together for writing, using numbers for doing math. So maybe telling time, money management, adding, subtracting, maybe when they're ordering at a restaurant, figuring out the tip, things like that. Aphasia can it affects everybody differently. So I don't think I've ever seen two people with aphasia that are the same. And it's all dependent on the severity, and the recovery depends on the cause, the extent of the damage, the family support, and the treatment. And there is a study linking early treatment to long-term improved speech outcomes. So in this study, it showed that it looked at people who got early treatment for aphasia with speech language therapy and then those who did not. And it showed 1 month post-stroke, patients who received early treatment showed better speaking abilities. And then 1 year post-stroke, more hours of early speech therapy correlated with better patient outcomes. And aside from just helping them improve their speech, another reason this could be is because with driving the early benefits is that they were able to kind of self-manage. So they instilled effective strategies, motivation, and engagement with communication supported activities. So since they saw us early, we were able to teach them a bunch of strategies that can help them, and then it just kind of sets them up for success. So another area that we evaluate and treat patients is motor speech disorders. So motor speech disorders result from neurological impairments affecting the planning, programming, and control or the execution of speech. This is very different from aphasia because aphasia is the language, the understanding, the expressive Motor speech, their cognition is usually intact unless they have something else, like dementia with it. But typically their comprehension and their ability to communicate is okay. It's just the words are coming out incorrect. They're coming out slurred, or maybe with apraxia, they're coming out the wrong sounds. So yeah, it's just important to note that because sometimes people might hear the speech concerns and assume that something is wrong, but they actually have really good cognitive skills. So common etiologies for motor speech disorders is Parkinson's, ALS, MS, Huntington's disease, cerebral palsy, and stroke. And then something else that I want to add is a lot of these conditions that cause motor speech disorders are neurodegenerative. So that means it's going to get worse, right? So early intervention is critical to be able to provide that counseling and develop a plan for as the disease progresses. So maybe you have somebody with ALS come to your clinic and they don't have any speech symptoms yet. It still would be helpful to refer them early on because we can get a lot of baseline information. We can kind of set them up for expectations and kind of plan for what we will do along the way, along the course of the disease. And with ALS, it's really cool because now they have voice banking. So they can see somebody while their speech is still really clear and get samples of their voice recorded to use that later when they have to use it over a computer. So it could be more personalized. The other thing is, as the disease progresses, it's going to change. So check-ins with us to kind of see how things are going. Maybe we see someone early on with Parkinson's, and then we see them again a year later, and they have worsening concerns with their speech, or maybe they have trouble swallowing. That might be a new development. So we can kind of tailor the treatment and address their concerns. Also, the other reason for early intervention is just giving them these strategies early. So let's say we have someone early on with Parkinson's, we can tell them what to expect and then what they can do when that happens. So they're better prepared and it's less anxiety inducing. So we offer a program in our department, which is called the Speak Out program. And what it does is it empowers people with Parkinson's to speak with intent. So it's an evidence-based treatment developed by the Parkinson's Voice Project. It's very similar to LSVT, the Lee Silverman Voice Therapy Program. It transitions speech from automatic functional to intentional acts. So people with Parkinson's have damage usually to their basal ganglia, which controls it causes them to have difficulty with automatic functions. So speech is an automatic function. So we kind of try to change that pathway to have them focus on intentional speech. And if you ever look at like before and after videos, it's amazing how much their speech can change from just really focusing and being intentional. And we do tons of practice, and there's a hierarchy of how we would address this. It can help with overcoming decreased loudness, poor breath support, and decreased clarity of speech. And then it helps regain and retain speech and swallowing. So there's actually some research showing that when patients work on the Speak Out program for their speech, it could actually shift over to swallowing as well. And this is because of the shared musculature between the swallowing and speech. They may be improving their breath support. The muscles are getting stronger. So that's why it can kind of carry over. So this program combines education, individual and group session, and daily home practice, and then continuous follow-ups. And having individual and group sessions is really great because we can work with the patient one-on-one to do the individual, and then they can kind of carry over their skills in a group and generalize what they're learning. Okay, so next area is cognitive communication. So this usually is after a stroke, traumatic brain injury, or a concussion. And the cognitive communication is tricky. Some patients, it's very obvious, and it's really easy to tell if they're significantly impaired. But often, like I was saying earlier, with concussion, it's usually subtle. So I'm just going to go over the areas and then we'll get into that some more. So one is short-term memory, so being able to recall maybe what they did yesterday, working memory, so task completion and following directions this is important for. Working memory is basically your ability to hold information and manipulate it. Difficulty remembering planned actions, so they may forget to take their medication, they may forget their doctor's appointment. Difficulty retrieving information from their memory. And then there's attention. So shifting attention between tasks, that would be like going from one task to another. So somebody taking notes while they're reading and having to shift back and forth from the reading material to writing. Selective attention. So an example would be, say a doctor is giving a patient instructions on their care, but there's like a lot of noise in the background. They might not be able to focus their attention on what the doctor's saying and then miss information. Sustained attention, being able to keep your attention focused on something to complete a task, and then reduced attention span. So maybe during conversation, they're getting really distracted. Some other examples of higher level cognitive communication skills are executive functioning deficits. So this is like difficulty with organization and planning, difficulty initiating tasks, impaired problem solving, difficulty with mental flexibility, difficulty with inhibition or impulse control, and impaired self-monitoring. And something I want to share about that is I had a patient who had a stroke and his main concerns was his executive functioning. So he actually had ADHD before his stroke, so he struggled in some of these areas. And then adding a stroke on top of it, he just was having such a hard time getting started with anything and like how to navigate it. And he would get so overwhelmed. So I saw him and he was actually at his retirement point and he had his own business. So there was a lot of things that needed to happen in order for him to close his business. He had to close out projects, pass them on to the appropriate people. There was a lot of meetings to be had and phone calls and paperwork to be done. And it was just, didn't even know where to start. So we actually worked on his executive functioning in his session, and I was able to provide him with tools to better organize himself. And what we would do is we'd practice that in the session. So we'd have him bring in, okay, these are the 3 major tasks that need to happen to close my business. And then we would break it down into smaller, more manageable amounts. And then his homework would be for the next week or two, he has to go through his checklist and get the things done, and then report back to me any challenges. And he had a very supportive wife. So she was able to really help carry over whatever we did in the session. And they had like a routine where each day they would pull out the planner and things like that. So another area is processing deficits. So they might have slowed speed of their processing and they might have difficulty keeping up with conversations, especially in a group setting, and they might get tired more easily. So a lot of the time, these cognitives, if the patient has very mild cognitive impairments, sometimes it doesn't even show up for them until they go back to work or until they go back to school. Because day to day, maybe they're not doing anything that really challenges their cognitive skills. But once they return to their working environment and there's so much attention and shifting and having to remember all these things, that's when they start noticing. So this is where if you have a patient who has a stroke, even if it's high level, maybe you can ask some questions about how's your memory been? Or like, is there anything that you were doing before your stroke that is more difficult now? Because we may be able to help them. So now I'm going to talk about SLP's role in voice disorders. So a voice disorder occurs when voice quality, pitch, or loudness differ or are inappropriate for an individual's age, gender, cultural background, or geographic location. So some symptoms you might notice is changes to their pitch, changes to their vocal quality, or the loudness of their voice. Oftentimes, patients with Parkinson's have a really, and it might be really monotone. So those are things that we can work on with them. Increased vocal effort associated with speaking, decreased vocal endurance. They get tired more quickly when they're speaking or running out of breath when they're speaking. And then etiologies, it could be structural, so vocal nodules, edema, polyps, trauma to the vocal folds. Maybe they were intubated before and they have some trauma to their vocal folds. It could be neurological, so Parkinson's, recurrent laryngeal nerve paralysis. Misuse is a very common one. We see a lot of teachers or maybe people in the military who have to talk for a living and they're not using their voice as adequately as they could. So we could do training with them, how to use their voice more appropriately so they aren't developing vocal nodules or they aren't having that like strained voice quality. And then another area is psychogenics. So there are psychogenic disorders that can come up that are triggered from a lot of stress and anxiety, that's still a voice disorder. I also see patients sometimes who have reflux. So their reflux comes up into their pharynx and it's constantly touching the vocal cords. And what happens is the throat starts to get inflamed, kind of to protect. So the area above the vocal folds will kind of close to protect so the acid doesn't get to it. But what happens is it changes their vocal quality. So in conjunction with a doctor managing their reflux, we could recommend behavioral things that they could do to kind of prevent that and ways to optimize their voice. And one more thing I want to add for voice is we always need an ENT consult when we get a voice evaluation. So you can send a voice evaluation to us and we can complete the evaluation, but we can't start treatment until an ENT signs off and they do a full assessment. And the reason for this is we need to make sure that there's nothing structural going on that we're missing. We would never want to start voice treatment and do like months of treatment and it's not getting better, and then later to find out they had a tumor or something near their pharynx. So always we'll get a ENT consult and then they can kind of be consulted as needed. So this next one is a big one, our role in dysphagia management. So I've actually done a lot of work with dysphagia, having worked in long-term care, skilled nursing, and acute care. We actually don't offer dysphagia, unfortunately, in our clinic, just due to legal reasons and safety risks being in an office building. I know a lot of the hospitals on island offer outpatient services for that, but I'm going to go a little bit into what to look for here. Okay, so dysphagia is a swallowing disorder involving the oral cavity, the pharynx, the esophagus, or the gastroesophageal junction. And consequences could include malnutrition and dehydration, aspiration pneumonia, compromised general health, chronic lung disease, choking, and even death. So I'm going to go over some of the common causes. There's so many, and sometimes it's even idiopathic and we don't know the cause, but these are some common ones. So stroke, Parkinson's, dementia, critical illness, endotracheal intubation, spinal cord injury, intellectual disabilities, TBI, vocal fold immobility, head and neck cancer, GERD, and myasthenia gravis. So signs and symptoms of dysphagia. An obvious one would be drooling and poor oral management of secretions or bolus. So maybe they come to you and you can see them drooling when they come to your office, or family is reporting that they keep spitting out their food. Another one is coughing, throat clearing, and choking while eating and drinking. And it's funny because sometimes families don't know that these are signs. So I might notice during my evaluation, a patient is clearing her throat every time she takes a sip of water. And I ask the family, does she do this usually? And they're like, oh yeah, she just does that. She doesn't have trouble swallowing. It's just phlegm in her throat or things like that. And then we might do a full assessment and find out that there's actually something going on. Food or liquid remaining in the oral cavity after the swallow. So that would be like oral residue, or also known as pocketing. Extra time needed to chew and swallow. So maybe they report that they're having to take an hour to complete their meals, where before it was only 20 minutes. A common one is complaints of food getting stuck in the throat. That is what we call pharyngeal residue. So usually a patient can feel that sensation, and it's because something's going on with their swallow. Maybe their muscles aren't strong enough to get everything down. So definitely an indicator for referral. They could have complaints of pain when swallowing. A change of vocal quality after swallowing is another big one. So if you hear your patients talking to you and they have a really gurgly quality to their voice, the vocal cords are the last thing at the top of the airway of protection. So if the vocal cords are wet and the voice is wet, that means that there's some liquid, whether it be secretions or something they drank, in the upper airway. And that is a risk that it could continue going down the airway into the lungs. Difficulty coordinating breathing and swallowing. So this is common with COPD sometimes. A patient is wired to survive, so breathing is going to trump swallowing for a body. So if a patient's taking a drink and they do have shortness of breath, they might take a drink while they're swallowing, and that could cause aspiration. Another big red flag is acute or recurrent aspiration pneumonia or respiratory infection. So maybe it wasn't even diagnosed as aspiration pneumonia, but you have the same patient who keeps coming back and keeps getting pneumonia. It might be beneficial just even to rule out that it could be a swallowing disorder, because we could give recommendations and things to kind of prevent that. Another one is changes in eating habits. So for example, avoidance of certain foods and drinks. I often have people say, I can't eat rice anymore, or I can't eat things that are crumbly like crackers or cookies or chips, and they may avoid eating those things. And if they never had a problem with that in the past, then that's definitely a red flag to take a deeper look. And then another one would be weight loss, malnutrition, or dehydration. If somebody is having trouble swallowing, likely they will probably avoid it or not be able to do it as often as they could before. Okay, so SLPs play a central role in assessment and management of individuals with swallowing disorders. We can identify signs and symptoms of dysphagia. So we usually do a clinical swallow eval or a bedside eval, where we observe them while they're eating and drinking and see if we're seeing any symptoms or any concerns. And then this is a big one, identifying normal and abnormal swallow anatomy and physiology supported by imaging. So we would complete a modified barium swallow study or fiber optic and endoscopic evaluation of swallow. So that's a scope. And the reason this is so important is we can't treat what we don't see. So typically anyone who has a new swallowing impairment should receive some type of imaging. It's like if you had a patient who fractured their arm, you wouldn't just blindly decide what to do. You would want to get an x-ray, right? So it's the same type of thing. It could help us to be able to identify what muscles are impacted, what would be the safest diet, just things like that. We also provide recommendation regarding diet textures and thickened liquids if clinically appropriate. And this is also a big one. So I never recommend thickened liquids without doing an instrumental assessment. And the reason is I want you guys all to think about, if after we get off this talk, you're only allowed to drink your liquids thickened for the rest of the week. That would be horrible, and nobody wants to do it. There are times when it's necessary, or the patient really wants to prioritize their safety, or they don't have a choice. But I will not recommend that for someone unless I'm 100% sure that that's the best thing for them and they want to do the most restrictive, careful approach. And the reason for this is thickened liquids is shown to a lot of patients have dehydration. So if you think about it, you really don't want to drink the just stop drinking altogether. This can also cause UTIs because they're not using the bathroom as often. they could definitely have a reduced quality of life because I haven't met many people who enjoy thickened liquids. And then they might have more residue due to the thicker consistency. So there are times where a patient may start coughing and the nurse just gives them thickened liquids. But we don't want to do that because we don't know what's happening in with their swallow anatomy. So there's been times where I've done an MBS and the patient swallows water and there might be a little bit going in the airway, but they're able to clear it out. But then when they swallow the thickened, it's so thick because their muscles are so weak that it's just sitting in the throat. And that's actually worse because they can still aspirate that. Another thing is if a patient's aspirating everything and they're also aspirating thickened, I would rather them aspirate thin water than thickened because thin water is easier to clear out of the lungs where thickened liquid has like starches in it. So those are all just things to think about. We also provide patient and caregiver education on aspiration precautions. So sometimes patients don't want to do what we're recommending. So they might not want to eat pureed food and thickened liquids, and that's okay. That's their choice. We never we can't force a patient to take a medication that we're prescribing, so it's the same thing. They can choose not to, but we can educate them on the risks and we can make sure that the caregivers are aware to make them as safe as possible. So it might involve like feeding them slower, taking smaller bites, taking a sip of water every time they eat some food. Another thing is implementing swallow exercise program to improve muscle function. So sometimes the muscles may not improve if it's degenerative, but if they had a stroke, there's still time to repair those muscles. And there's actually swallowing exercises that we could teach the patient to strengthen their swallow. Sometimes after a stroke, a patient's NPO. And the tricky thing with that is if it's like the use it or lose it principle of neuroplasticity, we need them to be swallowing, even if it's just dry swallows or little ice chips to try to maintain that ability. And then a huge thing that we can provide is navigating issues related to quality of life for individuals and possible like palliative care discussions. So sometimes people are really sick and they can't swallow anything, and maybe they don't want a feeding tube, and maybe they want to enjoy their favorite food one last time. So we can talk as a team about those options, and I can give insight into what their current function is, what the risks are, and we can lay out different scenarios. I actually had a patient once who he had a terrible, terrible swallow in his MBS. He actually wasn't even in the hospital for pneumonia. I think they referred him to me because he was coughing. Didn't have pneumonia, didn't have a history of pneumonia, but he was aspirating everything. But he was also a very active person. He walked 5 miles a day and he cleaned his teeth like somebody I've never seen before. He had all the dental devices and he just did really good oral care. And the doctor was talking about potentially hospice, but we talked as a team and we were kind of all in agreement that he's not demonstrating pneumonia. So while this is scary that his swallowing is like this, he might be combating the pneumonia through his exercise and keeping his mouth really clean. And the patient was adamant about not going on hospice and not getting a feeding tube. So we were able to discharge him with follow-up speech to continue working on strategies to keep him as safe as possible and reduce the risk of something like that happening. And then for palliative care, I mean, a lot of times maybe a patient just wants comfort feeding, so we can give recommendations on the safest diet. Sometimes it might be thickened liquids because if somebody's really out of it and really sick, they're going to be choking when they swallow, and that's not really comfort. So we can kind of work with the family to figure out what the goal is. Okay, so that is an overview. I'm going to jump really quick into referral indicators or red flags for you guys to pay attention for and maybe being able to refer some people for speech if it's appropriate. So for communication, changes in patient speech clarity and ability to be understood. So their speech might be slurred or hard to understand them. New difficulty expressing wants and needs. So maybe in your evaluation, they can't report their pain or they can't request anything. New difficulty understanding information, so following instructions or answering your questions. Reported difficulty with reading, writing, or math skills. Caregiver or family report of decline in speaking or comprehension abilities. Difficulty naming objects, change in voice quality, or difficulty finding the words. For cognitive communication, you want to look out for them reporting difficulty remembering things, difficulty following conversation, or maybe they can't stay on task during your evaluation, difficulty safely navigating an environment, new difficulty with planning or sequencing tasks, change in orientation, knowing where they are, the date, etc. New difficulty navigating work or school tasks, and then history of some type of neurological injury. And the last one is dysphagia, history of dysphagia or on a modified diet. So if somebody's been on a modified diet for a long time, it might be worth taking a look at to see how things are going, if they're still doing their strategies, things like that. Weight loss, dehydration, failure to thrive, throat clearing when eating or drinking, coughing or choking, or hearing a change in their vocal quality when they're eating or drinking. So you want to listen for that wet, gurgly vocal quality. Taking longer to consume meals, decrease in intake, pocketing food, pain when swallowing, or the report of food getting stuck. And I also want to add here that sometimes I get referrals for people saying food's getting stuck and they point to their esophagus area. And we can still assess them because people with esophageal dysphagia, it's still a type of dysphagia. And while it's not really our area, we can screen it and we can refer to a GI doctor. Sometimes patients might have like a stricture and food's getting backed up and coming up to their pharynx. They might benefit from strategies such as making sure they sit up after meals, and we can kind of go over all that. And when we do a modified barium swallow, if we suspect GI concerns, we can do a sweep where the machine comes down and looks at the esophagus. It's not as thorough as like a GI exam, but then we can refer them on if anything concerning comes up. So now knowing all of this, you now know that collaborating with an SLP could have positive outcomes. So your patients can have better communication with their family and even with you with the tools provided. They can improve their ability to communicate their pain and participate in the medical decision making. So maybe they have a way to communicate, but we just haven't identified it yet. And we can improve this ability so they can better participate with you. Also, cognitive communication, increased independence in daily activities with use of compensatory strategies, and then increase safety in daily routines. So we can identify what we think, how much support that patient needs. Sometimes patients can talk like everything's fine, but when we dig a little deeper, there's like some really big safety concerns. So we can recommend like the wife needs to be with him 24/7. I actually want to just give a quick example. I have a patient that he has cognitive deficits from a stroke and he wanders. So he wants to go for walks because he wants to maintain his independence, but sometimes he wanders off and he doesn't remember to tell the wife. So working with her, we did training with him to practice using his phone to call the wife. We had him practice his password and had him practice dialing her number. We added like a sticker on the phone with instructions and emergency numbers, and she was able to set up a tracking through his phone. So if he did wander off. So that's just an example. And then swallowing, prevent aspiration pneumonia and malnutrition due to dysphagia, educating family to carry over recommendations and strategies. And this in turn can lead to decreased medical complications and less hospital readmissions. So even if the patient doesn't want to participate in the therapy or maybe be on a really disgusting diet that they don't like, at least we can tell them how to make it as safe as possible. So the takeaways from this, when in doubt, refer. SLPs can assess and provide recommendations for areas of concern. Early intervention can lead to better outcomes. Delays in referrals can result in worsening deficits and decreased quality of life. Improving communication skills can help patients to accurately report symptoms, follow instructions, and participate in medical decision-making. Managing their cognitive symptoms can increase their safety. SLPs provide person-centered swallowing recommendations to increase safety and maximize their quality of life. We provide caregiver education and training to maximize participation and carryover of skills. And as SLPs, we believe that communication is a human right, and we will work to make sure it's accessible and achievable to all. And I do want to add one more thing because this is kind of a reality situation, but we do bill insurance. Now, something that is difficult at times is patients who've had an older stroke. I will tell you, I've seen patients with older strokes and the insurance is approved and they made tremendous progress. So for example, I had a patient who I think her stroke was 5 years ago. She was referred to me for her aphasia. And I think when her stroke first happened, she couldn't do a lot of speech because she just had so much going on with the stroke. She has severe expressive and receptive language. She couldn't communicate at all. So her family was always guessing what she was thinking or what she wanted. So when she came to see me, we developed a communication board for her. So her speech improved. She was able to say her husband and her son's name, which was really cool. And then we had a board which we put her top requests she might ask. So she might ask, I'm hungry, I'm thirsty, can I use the bathroom? I want to lay down. And now she has this board that even though she can't get her words out, she could point and the family knows what she wants. So that was somebody whose stroke was long ago and it was still a really good success and there was still justification of what we can work on. But I do know sometimes insurance will like deny if it's not a new stroke or a new thing that happened. So this is again where my patient-centered interview is really helpful because I can use all that data to justify that something's happening with them and that they can benefit from services. Okay, I'm going to open this up now to discussion. If anyone has any questions.
Brittany, thank you so much for an excellent and very comprehensive presentation.
Of course.
We have a small enough audience. If anybody has questions, could you please unmute yourself and you can ask your question.
I have a question.
Yes.
So for patients that have like aspiration pneumonia secondary to like dysphagia and stuff like that, and then we're at the end of life conversation and on palliative care and everything like that, and the patient, like we want to give them food they want to eat, and you just give it for comfort measures when they're hungry.
Mhm.
What if the patient's family asks, oh, well, what if she gets pneumonia again? So if patient is on comfort measures, eating, even though we know it could cause aspiration pneumonia, and they do get aspiration pneumonia, are we allowed to treat that pneumonia with antibiotics at that point, or are we not allowed to?
That's a good question. I think it depends more on what the patient's like goals are because I've seen people come back to the hospital for like IV or something who are on hospice and then they just go back to hospice after. So I think that would be like the physician kind of talking with the family on what is okay to do, what's considered aggressive treatment. But usually for me, like I'm constantly explaining to the family like if it's a really risky situation, they have the right to still have it, but this could happen. So just kind of making sure that the expectation is known. But I think it just depends on the physician and if I'm not sure exactly what's allowed in actual medical intervention. But we also might recommend things that are easier. So if they really want to eat while they're on hospice, maybe we shouldn't go for like the steak lobster dinner, things that are just a little bit easier for them that they still enjoy. So just finding like the balance point.
I see some of our palliative care faculty in the audience, Dr. Fishberg, Dr. China, Dr. Morita. Any of you
Yeah.
would like to comment on that?
Thank you, Dr. Masaki. Well, of course, whatever we think is medically appropriate is quote unquote allowed. But I'd point out that, food going into the airway isn't treated with antibiotics. I mean, that it's the person, and that's why feeding tubes don't reduce aspiration pneumonia because the individual is going to continue to aspirate their oropharyngeal secretions, and that's essentially where all pneumonias come from. all the time. So, yes, if somebody spikes a fever and, people are thinking that there's an infectious etiology, whether or not it's, it probably has nothing to do with the food. It's just because they're aspirating their secretions. If it's consistent with the patient's goals, antibiotics can be given.
Thank you for sharing that. That's a huge thing that I try to share as well, because a lot of people think that, oh, they're aspirating, let's give them a feeding tube. And that's not like a light decision, because exactly like you said, if they're aspirating their food or their drinks, they're aspirating their secretions as well. And
Right.
doesn't solve that. So thank you for sharing that.
Of course.
Anything else?
Yeah, also, it's Naomi, Marita. IVs can be given in hospices too.
Mm.
IVs, sub-Q lines, so they don't have to go back to a hospital or ED for IVs.
Thank you, Naomi.
Thank you for
Yeah,
sharing.
you're welcome.
Yeah, I mostly know from the acute care perspective. So thank you for sharing that.
Are there any other questions for Brittany?
Oh, perfect. Let
Oh.
me pull that up really quick. I have a slide with that.
The contact number, right?
Yes. Where did it go? Ah. You guys can see it?
We can see it. Thank you, Brittany.
So I also shared this link. It has it's like a tool for physicians, referral guidelines, and there's one for a skilled nursing, home health, and I think acute, I'm not sure, but it has different questions, like a checklist, that you could run through and yes or no. And then if the answer is yes for anything, that it might warrant a referral. So I thought that would be helpful for you guys, in addition to this presentation. And then this is our information. So again, we don't take dysphagia referrals, unfortunately, but any speech, language, cognition, voice, I would be happy to see your patients.
Thank you so much.
Yeah.
Are there any other questions? I just want to remind everybody, you need to do the evaluation to get your CME credits, and John has just put the evaluation link into the chat box. So you can use that to go into the evaluation. Any last questions for Brittany before we close out? I see a lot of comments about excellent presentation. Brittany, everybody really enjoyed what you said. Thank you so much. I agree, it was very comprehensive and very useful.
I really wanted to share like the whole scope and give as much as I could, but keep it under an hour. So it was tricky because there's a lot of areas that we touch on, but I'm glad I was
You
able
did a
to
great
share.
job. Yeah.
Thank you.
Okay, one last chance for questions. If not, we're almost at time. So thank you again, Brittany, for an excellent review for us. And for our audience, see you again next month. Don't forget to do your evaluations. Thanks, everyone.